Good evening. It is a rare event for me to come here and participate in this session. I used to be a very active participant many years ago, but for the last several years, I must apologize that my absence was partly because of my growing old, also a little bit of laziness. Nevertheless, I always thought that these sessions are very enlightening. And I have some few postgraduate students here. I was encouraging them to come and participate in these. Every session, you will learn something. You may not be the brightest person to learn everything in one session, but a topic like this, for example, chronic constipation, is often less mentioned, especially in a elegant parlance. You rarely ever mention about constipation as a subject. It's not a topic worth discussing, but I would just mention it as a joke that in the good old days, Mughal days, one day Birbal asked Akbar about this business of constipation. So he ridiculed. Next day, what Birbal did was he locked up all the latrines in the palace. So as the day passed, Akbar became very restless and finally he had to concede to Birbal for that. I always wonder, human being is such an elegant creation. You look at the blood, when it passes through the kidney, it becomes urine. It passes through the liver, it becomes golden in color to become bile. Human sweat is a different phenomenon. Cerebrospinal fluid is still yet another very clear fluid. You cannot say the same thing about the scavenger corner or the Brahmapuram of the human body, the GI tract. I'm sure she will enlighten us. When I met her, the first thing I said was, I knew her father very well, Prem Nair. So it is the illustrious daughter of a great man with a lot of wisdom. I invite you to start your topic on chronic constipation.
Thank you so much for that very wonderful introduction, sir. I am honored to be here, and I'm honored that all of you have come here to listen to this topic, in spite of it being a very rainy day during monsoons here in our state. I would like to start off by agreeing with everything wholeheartedly that Sir just said. This is a topic that is not often kept as a main subject of discussion in any kind of meeting like this. That being said, especially for the postgraduates here, when you finally are in your practices in your respective hospitals, this particular issue is something that you are going to see in your patients every single day. Though as a doctor, sometimes physicians or any of us, we simply write a laxative and we send their patient on their good way. Constipation is something that can be incredibly debilitating and incredibly challenging for a person to have to deal with in their day-to-day lives, especially since it's not necessarily seen as something that's life-threatening. It's not often paid enough attention. So I'm very proud today to be talking on chronic constipation, and I hope that there'll be something that you all can take back and improve your own practices with. So I am sure that most of my senior faculty and members here will know all of these introductory points, and I'll run through it very quickly. But as we all know, constipation is essentially difficulty in passing stools. It's as simple as that. There are so many classifications and definitions for it. Essentially, the Rome classification, that is what is been used for most of the irritable bowel syndrome definitions. It defines constipation as 2 of any of the following 6: fewer than 3 bowel movements a week, straining for more than 25% of the time, lumpy or hard stools more than 25% of the time, a sensation of obstruction at the anus, or a sensation of incomplete evacuation, or even the requirement for manual maneuvers such as digital evacuation. And when we look at this definition, you can see that actually there are a very wide range of issues that are covered under this single terminology of constipation. So there are essentially two types, primary and secondary. As physicians sitting here, I'm sure that you may know the secondary causes of constipation far better than I do, even. So, primary, secondary. Secondary may be because of medications, metabolic causes, neurogenic disorders, primary colonic disorders like malignancies, etc. And then you have this situation of primary constipation, which is either called chronic idiopathic or functional or psychogenic, psychologic, whatever one may want to call it. That is where I would like to focus the energy of this particular talk on, because that's the set of population that kind of go untreated or unrecognized. So I think I won't get into the details of this, but these are some of the causes of secondary constipation. These include even issues like spinal cord injuries and tumors, cerebrovascular diseases, multiple sclerosis, etc. So, when it comes to the types of primary constipation, and this is especially for the postgraduates here, this is a very important distinction that we all need to make, because the treatment for these three types of primary constipation is essentially entirely different. Normal transit constipation, slow transit constipation, and defecatory disorders. Normal transit constipation are those conditions or that set of patients wherein the actual peristalsis of the large intestine is normal. But there may be various factors, including hard stools and lack of exercise on the patient's part, that lead to an inability of the stools to actually move through the bowel, even though there is normal peristalsis. The second condition is slow transit constipation. And in this particular case, the propagative or propulsive movements of the bowel are actually diminished or sluggish, because of which, even if stools are soft, they are incapable of reaching the rectum. And the last set of disorders are defecatory disorders. That is, your peristalsis is normal, everything reaches the rectum at the right time. But the problem is there is a lack of coordination between the peristalsis or the push of the rectum and the relaxation of the anal sphincter. So these are three completely different pathophysiologies for the same outcome, and that's an inability to pass stools. And when we get into the medications, I would like to, remembering this particular classification would help understand what's the best way to treat each one. Another concept to keep in mind is that, again, this is one of the multiple classifications of constipation, and it can get, frankly, quite confusing. So I don't want to kind of muddle the waters. But that being said, one extra symptom that is important to keep in mind when discussing constipation is abdominal pain. Because, again, various medications will help relieve constipation differently if there is a background of abdominal pain or no abdominal pain. We often, very loosely, even as gastroenterologists, we very loosely use this word irritable bowel for everything. But only when constipation is combined with pain are we supposed to actually call it irritable bowel syndrome. Whenever constipation is not combined with abdominal pain, it's called functional constipation or chronic idiopathic constipation. So, coming to just running through some of the tests we can do for constipation to help us understand which of these three categories we fall into. Obviously, we always need to get a colonoscopy. I'm probably partial to this as a gastroenterologist. My professor, Sharma sir, used to say, "Why do you want to take gastroenterology? You'll end up being a luminologist that doesn't know anything except the inside of the bowel." But that may be true. That being said, we always start evaluation of constipation with a colonoscopy just because of the very high incidence of the sinister colorectal carcinoma. And it's very important, especially if a person is above 50, that we get a colonoscopy done prior to writing anyone with constipation off. But these are some of the few situations we see when we do a colonoscopy, from fecal impaction, colorectal cancer, diverticulosis, solitary rectal ulcer syndrome, that usually is what we see in the scopy for a patient that has defecatory disorder. The motion is pressing on the rectal floor, the pelvic floor, but the anus doesn't relax. So they develop deep ulcers in the rectum. And that is an indirect sign of defecatory disorders, the last of the three categories we were discussing. So, most of the conditions we do find, however, on a colonoscopy are all causes of secondary constipation. When a patient has constipation and they have a normal colonoscopy in general, the next test that we do is what's called an anorectal manometry. We try to simply explain it to the patient as an ECG of the anus, anorectal complex. Essentially, it's nothing more but the a sensor or a probe passed through the anus that helps us to understand the muscle contraction and or relaxation during the act of defecation. We inflate a balloon inside the, can we see the mouse? No. Okay. So we inflate a balloon inside the rectum and we actually ask the patient to pass it just like they would if they were passing stools, and we watch what happens to the various muscles as they do so. It's a very simple OP procedure, takes hardly 5 minutes, no need of sedation, no need for even fasting. Just come in the morning and get it done. And one of the most important reasons why we do this is to understand what is anorectal dyssynergy. Okay. I'm not sure if you can see this. So, in a normal person, the moment that the rectal, so the upper line is the rectal pressure and the lower line is the anal sphincter. So, normally, common sense, when the rectum pushes, the anus has to relax so that the motion can come out. So, there are various types of anorectal dyssynergia. Yeah. Wherein type 1, when you have rectal contraction, the anus contracts along with the rectum. So ultimately, no bowel movement. Second is your rectum doesn't contract at all and the sphincter doesn't relax at all. Again, the net output is absolutely no bowel movement. Third type is the rectum contracts, but there is insufficient relaxation. And the last type is that neither does the rectum contract, neither does the sphincter relax properly. So, though this is, this might seem overly complicated, essentially, irrespective of the type of disharmony between the two, the net outcome is a failure for motion to be passed. So we'll get to the how this affects treatment in a couple of minutes. The next study is called a colonic transit study. So the anorectal manometry can only really tell us what's going on in the rectum, but you have the 1.5 meters of colon above it. So how do we know if that's normal? This is a very, very simple study. In fact, this is something that can be done in even if you're doing private practice at home. Actually, Professor Ganapati Rao sir, I had the fortune of learning medicine with him. He used to just take a Ryle's tube and cut it with a blade into many small pieces. And he would do this exact test in patients that came to our OP in medicine with chronic constipation. Essentially, we make the patient swallow multiple markers, 20 markers 3 times at 0, 12, and 24 hours. And we just take two plain x rays of the abdomen. That's it, two plain erect x ray abdomen. One x ray at 36 hours from the first marker intake, and another at 60 hours. And you can see this is an example of one of the x rays that we took. And we count how many markers are there at 36 and 60. Anything more than 14 markers at 36 hours or more than 36 markers at 60 hours means that this patient has slow transit constipation. That means that the colonic peristalsis is sluggish or not happening. And this is very, very important for us when it comes to treatment. And I'll give you a very simple example, though we'll go through it later. The most common thing we tell any patient that has constipation is what? Make sure you take fiber. ഇലക്കറികൾ കഴിക്കുക, റാഗി എടുക്കുക, millets എടുക്കുക, whatever items we all individually advise for fiber. But when a patient is diagnosed with slow transit constipation, fiber actually worsens it. Because they don't have peristalsis, they are not able to push out the hard fiber inside their colon. So this is a very simple thing that can be done to actually help us even guide a patient on what kind of diet advice we give to them as a physician, which is why I thought we could spend a minute on this, because it's something that can be done by anybody. You don't even need to refer to any kind of a higher center for this. Then we have all the CT and MR tests. I'm not going into them in detail. I just wanted to mention one specific test, and that is an MR difficography. This is especially done in those specific patients, most commonly in women, where they have rectoceles, cystoceles, or maybe ureterovaginal prolapses. And these prolapses put pressure onto the rectum, because of which they have a functional defecatory disorder, but actually your tests all don't make any sense. You get confused. Your anorectal manometry will not show anything, and actually it ends up being that they have some kind of a prolapse. So in patients where our ARM or anorectal manometry is unclear, we often go for a defecography just to help us understand what's happening with their vault, especially in women, especially in elderly women who have already undergone a hysterectomy. This is a very common issue that often gets missed. So I think as a diagnostic approach, this is at least a very basic thing that we follow, is whenever a patient comes with chronic constipation, we first look for all your secondary causes, whether it be thyroid function tests, renal function, liver function. Make sure that you know what are their medication history. Are they on any anticholinergic drugs, antipsychotic and psychotic drugs, tricyclic antidepressants? All of these things can cause constipation. Get a colonoscopy done or a stool occult blood, at least making sure that we're not missing a malignancy. And once we have assessed and ruled out the secondary causes, then we have a case of so-called primary constipation. Assessing the anorectal function will help us differentiate the dyssynergic defecation as a separate set. If your anorectal manometry is normal, then we do a colon transit time. And based on that, we can divide our patients into slow transit or normal transit. So this basic classification of chronic constipation is very important when it comes to treatment. So treatment, I think we've all, from the days of MBBS, we've all seen these same tables of tons of laxatives, no real classifications on how to use them. A lot of us just kind of play with whichever one we think is working at that particular moment of time. I don't need to go through this. I'm sure most of you may even be prescribing it more than me. But we have our bulk forming laxatives, we have our stool softeners, all of our osmotic laxatives, including lactulose lactitols, as well as our pegylated glycol or pegleg. And then you have some of the stimulants. Most common that we use is dulcolax, sodium picosulfate, and then you have, all your senna, aloe vera gel. And honestly, I think especially in our region, we have to add Kayam to this list, because I think a vast majority of patients coming to us in the OPDs are at least on Triphala or Kayam, although I don't know 100% what the contents of that actually mean. These are also very effective stimulant laxatives. Then I would like to also mention a few of the newer drugs. I think this is still a very exploratory area. I see a lot of people prescribed these when they come to us for a second opinion. These are some of the newer drugs. And I think everybody, whether it be physicians, specialists, whoever it be, everybody is still experimenting with this set of drugs to understand which will be most effective for who. So, very briefly on these, lubiprostone is a prostaglandin and agonist. Basically, it stimulates chloride channels both directly and indirectly and pushes water from our intravascular space into the bowel and increases our motility to some extent as well. Then we have linaclotide and plecanatide. These basically increase the production of cGMP. And this particular mechanism increases both the fluid rushing into the intestine, as well as it to some extent increases our intestinal transit. Prucalopride. This is actually something I'm sure many of you also are quite familiar with, and this has been a fantastic drug. It is a serotonin 4 receptor agonist, and it facilitates both the excitatory cholinergic as well as the inhibitory transmission of neurotransmitters through the circular colonic muscles. Basically, it increases our propagatory propulsion of stool inside the intestine. And this is one of the very important drugs for a patient that has slow transit constipation. You will often find that all your dulcolaxes, your what do you call it, lactitol, loose, dufalac, none of them will work well in patients with slow transit constipation. This drug has been revolutionary in that, although there are cases where this fails as well. Then there is a new kid on the block. That's something called Elobixibat. I'm not sure why we keep having stranger and stranger drug names, but basically, this is a drug that targets our ileal bile acid transporter, and it prevents bile acids from being reabsorbed in the terminal ileum. The whole the whole circulation of bile acids from the ileum to the liver is cut off, and essentially it creates bile acid diarrhea, it creates steatorrhea. So though theoretically you should have so many side effects of this particular drug, vitamin deficiencies, increased gallstones, because you're losing all your bile acids. You should have, because high bile acids in the intestine can lead to colitis, hyperoxaluria leading to renal stones. So there are so many theoretical reasons why this particular drug should make no sense at all. In fact, we spend a lot of time and energy trying to treat bile acid diarrhea in patients that have that as a primary problem. But that being said, for some reason, whatever trials have been done on elobixibat have not actually shown any of these. That might be a pharma driven thing, who knows, but still, as of right now, especially in long term diabetic patients who have gastroparesis, neuropathy, all kinds of neurogenic issues because of long standing uncontrolled diabetes, they do very well on elobixibat. And this is something that if some of you face this particular issue in your OPs, you can think about. Now, all of these drugs come with their whole platoon of side effects. something as simple as dietary fiber, fibogel, can actually be very distressing to a person who has slow transit constipation. We have to remember that our microbiome, our gut bacteria, they feed off of fiber. And just like when we eat, gas is our byproduct. When the bacteria eat fiber, gas is their byproduct. So essentially, you can have a very big issue with bloating and belching and abdominal distension when patients take fiber, which is why, unfortunately, it's not a solution for all kinds of constipation. You have your osmotic laxatives, they also can cause exceedingly large amounts of flatulence. Then you have lubiprostone, which has all kinds of complications that any prostaglandin would have, including flushing, headache, nausea, vomiting, etc. So, all these drugs, especially that newer set that we talked about, they do come with their own set of problems. So, then we reach this point. We've named about 50 different drugs. God alone knows when we use which ones. So, is there any kind of order to the chaos? I have to, unfortunately admit that the answer is no. There are no guidelines put out as to the right way to start laxatives, whether you have a step down approach, step up approach, any kind of step approach, there is really no guideline. That being said, there are certain amount of tricks that we can use as broad guidelines. In fact, India has come out with some broad guidelines from Dr. Uday Ghoshal. Sir used to be the chairman of gastroenterology from SGPGI. So his team has come up with multiple multicentric studies. He's come up with some Indian guidelines which actually have been very helpful when you face really difficult cases. In general, so we already looked at this table. This is the first set of our age old laxatives that I'm sure all of us are familiar with. Before going in for major testing with an anorectal manometry and colon transit time and difficography or whatever, we all can definitely try this particular set. Normally, the order goes as try fiber exercise and 3 to 4 liters of water per day. If that doesn't work, then we go with an osmotic laxative. If that doesn't work, we go with a softener. And if at that point there is still no response, so this is from the Indian consensus statement, then we need to make sure we start looking for the further classification of these three types of constipation. So again, regarding the first set, we mentioned, I think I mentioned this already, but if there is no bloating, or if a person is not already on a high fiber diet, only then we try bulk laxatives and osmotic laxatives. If a person has significant bloating or is already on a high fiber diet, it's advisable to hold off on fiber supplements and even on osmotic laxatives, especially lactitol and lactulose. Lactitol and lactulose should only be tried when a patient does not have bloating. One other point to keep in mind is that our stimulants, our Dulcolax tabs and suppositories, etc., they are actually supposed to be used only every third day. We are not supposed to give stimulant laxatives every day. The biggest problem with these laxatives is that they cause addiction, and then it reaches a point where patients just cannot pass without a stimulant. And we don't need to go into details with this, but basically, if you've tried all the initial set and nothing is working, that's when we go for manometry, ARM, colon transit study, and the rest of the MR difficography, etc. So, in general, if all of those tests are normal, then we call it as a typical IBS-C, and you can rest assured that if all of them are normal, the patient will be having pain as well, because they'll be having hyperstimulation of colonic nerves, etc. So, if your colon transit time is very long, you have an abnormal X-ray, all markers are in the colon, but the rest of your anorectal tests are normal, This is a typical isolated slow transit constipation. And in those particular patients, we call it colonic inertia, I think before, those patients do very, very well with prucalopride, starting off with 1 milligram, increasing it to 2 milligrams twice a day as the maximum dose. Now, if your transit time is normal, but all of the anorectal are abnormal, you have a pure defecatory disorder. And these particular patients might benefit from suppositories, but in general, you need to do what is called biofeedback along with enemas. And I'll get into a single slide on biofeedback to explain that in a moment. So, again, regarding the newer set of drugs, some broad guidelines, opioid or drug induced constipation, they are the set of people that do well with this lubiprostone drug. Slow transit constipation, the gold standard now is prucalopride, and always give prucalopride with a stool softener, otherwise, it may not be effective. Irritable bowel syndrome with pain, constipation, and pain, you can try some of these newer drugs, linaclotide, placanatide. And remember that until and unless you have done a CT and a colonoscopy and made sure there is no mechanical GI obstruction, it's absolutely contraindicated to try lubiprostone. Diet and exercise, I think there is so much information regarding that I'm not going to go into the individual foods, but I just want to again stress on the fact that normal transit constipation, you need high fiber diet and plenty of water. Low transit constipation, you need a low residue diet with plenty of water. And if a person has a defecatory disorder, there's no point in any diet alteration. Nothing will work until and unless we start giving them biofeedback and suppositories. Not suppositories, enemas. And regarding exercise, just one thing. Many patients will ask what kind of exercise. The most important kind of exercise is walking. All the gym and muscle training and yoga in the world will not help a patient as much as walking, because walking actually stimulates high peristalsis of the colon, and that is the most important exercise that should be told to patients with constipation. So, before getting to the end, just a few points. Biofeedback. This might be something that's new to many of you. Basically, what it is it's the same anorectal manometry probe we actually insert into the rectum, and we train the patient how to relax the anal sphincter when the rectum is contracting. So we physically inflate a balloon and the patient will feel like passing. And there are certain movements you can make of your legs, of your thigh muscles, that can help retrain the patient to relax the external anal sphincter when the bowel movement is trying to pass. So it sounds like it sounds complicated. It's a very easy process. We have patients come and meet us every 2 weeks, and over time you find that their manometry remarkably normalizes. It often takes about 6 to 8 sessions before they are able to retrain their bowel. Anal irrigation is another, which is essentially as simple as an enema. Enemas help in patients that have defecatory disorders. And in severe cases of constipation, these are all very severe situations, we go from actually inserting a permanent stoma in the appendix, so we flush water from there twice a week, and even to the extreme of having a stoma placed in patients that have very severe slow transit constipation. Remember, for patients who have chronic constipation, there is an increased chance for colorectal carcinoma. So it's important to remind patients to go for surveillance colonoscopies every 3 to 5 years. There has been a lot of talk on the role of probiotics in the management of chronic constipation. This keeps coming up in our meetings, but essentially what we know right now is that though there are many proposed mechanisms for how probiotics might help, there is not a single study that has actually shown concrete benefit. That being said, there are some Indian studies that have shown that methane producing bacterial levels correlate with the severity of constipation. So, whether in the future this might help, especially in slow transit constipation, is yet to be seen. And to end, this is again another discussion that keeps coming up, a top down or a step up. Do we start with these drugs like elobixibat and linaclotide, etc.? Though some societies are pushing for that, the reality is all of these drugs are habit forming drugs. And essentially, the less of the very high end drugs that we can give to patients, the better. So, the top up approach is still something, the step up approach is still something that I think most groups still advise, but that I guess is something that will all be left to our individual experience. So, with that, I end. I think I've gone a little over my time, but thank you for your attention.
Thank you very much for that very educative and very recent topic, recent advances in the therapeutic armament area. Please be seated. I think we have a few minutes for questions. Interesting topic. I am sure there will be a lot of questions to follow.
I think that definitely a step up approach. Usually, because we have the luxury of all the testing, we do tend to classify all our patients into normal, slow transit, or defecatory disorders. Normal transit constipation, usually based on their bloating symptoms, we give them stool softeners, maybe with some amount of fiber. Dufalac bulk is something that we tend to give a lot, which is lactulose with fiber, and we push them to start walking, fluid intake, and a vast majority will improve with that. For the slow transit constipation, prucalopride really helps. Unfortunately, once they started, we see that they end up being on prucalopride for for a very long time, and often all these drugs over time they become less effective. So then we keep trying to add more and more things to it. So it's still a big challenge, these slow transit constipation. I unfortunately have many patients that we've had to put a colostomy for, not a colostomy, an ileostomy, because they just cannot pass at all. There are some newer therapies, something is like that's called neural therapy, which is essentially the ganglia are the sacral ganglia are stimulated with a needle, and they do remarkably well. Some set of the slow transit constipation, when all these drugs fail, they do well with that. And defecatory disorders is biofeedback. Yeah.
Thank you for that good overview. It was very helpful for physicians, not going too much into the interventions, but the medical management. Thank you very much. One point maybe I would like to add, or even stress, which you already mentioned, is drug induced. Physicians use a lot of drugs which eventually results in constipation. For example, calcium channel blockers, morphine. It is said that many deaths in a patient with MI happens in the toilet because you give morphine, patient gets constipated, and then he strains at stool in the toilet and they collapse. So much so that some CCUs do not have a door for the toilet to observe that whether the patient is collapsing. This is one thing we have seen. So constipation due to morphine is a very fatal occurrence. And that's one point we should. And then there is furious diarrhea. Patient presenting as diarrhea, and actually it is a constipation. That seeping of fluid because of hard stools. So it is actually a manifestation opposite to constipation. That's one point probably all of us should keep in mind. And one of our old professors used to say, digestion is a process which starts with the right hand and ends with the left hand. So this is what he used to mention. So it's the left hand often that fails to do its job. Thank you.
Cinetraprid, can we add Bruclopride in that patient? For
Actually, the studies say yes, but we still don't add it together because they have similar actions in different parts of the GIT. There is no study that is actually showing proving safety. So we don't use it together, even though guidelines haven't mentioned that specifically, but we don't use them together. We usually change the prokinetic if we are going to.
I'm sure there will be a lot more questions. My simple answer to the whole problem, over the last 30 years, there has been a lot of urbanization and European style of functioning toilets. In the good old days, I don't think there was such an increased incidence of constipation when squatting was the norm. Increased fluid intake was the norm, as well as natural exercise like walking. Here, to go to the nearest shop, you have to take the car or auto rickshaw. Instead of that, she emphasized the point that walking is the best exercise. You don't have to go to the gym, you don't have to go for yoga, but the straightforward walking, we should start at the age of 1 till your death. That is the best answer. To that extent, I don't want to prolong the session. Fluid intake and exercise, she emphasized. She has beautifully described the pathophysiology of constipation and the management as it stands today. Thank you very much, Dr. Priya. We have